Welcome to Taking Healthcare by Storm Industry Insights, the podcast that delves into the captivating intersection of innovation, science, compassion, and care. In each episode, Quality Insights Medical Director Dr. Jean Storm will have the privilege of engaging with leading experts across diverse fields, including dietitians, pharmacists, and brave patients navigating their own healthcare journeys. Our mission is to bring you the best healthcare insights, drawing from the expertise of professionals across West Virginia, Pennsylvania, and the nation. Subscribe now, and together we can take healthcare by storm.
Hi, everyone, and welcome to another episode of Taking Healthcare by Storm. I am Dr. Jean Storm, the medical director here at Quality Insights. Today's guest is Dr. Tamara Ruggles, a board-certified geriatric pharmacist and fellow of the American Society of Consultant Pharmacists, who has dedicated her career to improving medication safety and quality of life for older adults. After years of working in a long-term care pharmacy, she saw firsthand how inappropriate medication use could lead to falls, hospitalizations, and even nursing home admissions. That experience led her to launch her own consulting company, which has grown from serving just a few rural facilities to supporting more than 20 long-term care communities across North Dakota. She is, as I say, a hero, but I say Shiro, and she is certainly a Shiro. She is also the founder of the Deprescribing Clinic, a community-based practice focused on helping patients and providers optimize medications, reduce side effects, and use tools like pharmacogenomics and antimicrobial stewardship to deliver safer, more personalized care. In addition to her clinical work, she hosts the Geriatric Pharmacy Focus podcast. Check it out. Awesome. So much high-yield information. And she remains closely connected to patient care through community pharmacy practice. Today, we're going to be exploring the power of deprescribing, the risks of polypharmacy in older adults, the role pharmacists can play in improving outcomes in long-term care, and what the future of medication management can look like if we truly prioritize safety, function, and quality of life. Tamara Ruggles, thank you so very much for joining me today.
Wow, thanks so much for that kind introduction. I appreciate that. My kids, they wouldn't introduce me in such a nice light as you have. So thank you.
Well deserved. So you spent years working in a long-term care pharmacy before launching your own consulting company and eventually the Deprescribing Clinic. What were you seeing at the bedside that you felt like you needed to make this change, that something needed to change?
Yeah, so as far as launching the Deprescribing Clinic, I've been a nursing home consultant pharmacist for over 10 years now. And as I'm consulting and as I'm seeing these beautiful people come in our nursing homes, you look at their medication list and you think, well, it's no wonder you fell and fractured your hip. You're on a benzo and an opioid and an anticholinergic, and you just look at all their different medications they're on. And I started thinking, for a couple years, I was thinking, man, if I could have helped this patient a year ago, 2 years ago, they might not be in this nursing home right now. And not that our nursing facilities aren't great, because they are, but most people prefer to be in their own home. And of course, we prefer that these patients don't fall and have fractures and have a decreased quality of life. So I really just wanted to get to these folks before they ended up in a position where they were having side effects and medication-related problems to prevent these kind of things from happening. And after a year of seeing it over and over again, I thought, that's it. I'm doing it. I'm starting it. And so that's what led me to launch the Deprescribing Clinic in 2023.
It is such an important priority. I mean, I don't know if people realize, deprescribing, like that needs it, like it's at the heart of geriatrics, and it needs to be there. Like we kind of just always want to, I think in our society, just add on other medications. But, the power of taking things away is huge.
Yeah.
Yeah,
And
definitely.
well, I think a lot of people hear the Deprescribing Clinic and think, wow, people go from being on 23 medications to 3 medications. And sometimes there is drastic changes like that in patients when you really get to the heart of it and dig and see what was first and what was second and the prescribing cascade. But big things can happen, big improvements in health can happen just by simple medication changes too. So yes, there are those huge drastic changes, but there are also simple changes that make drastic improvements in people's lives.
Definitely. And I've seen that myself. So that leads me to my next question. So, what does the clinic actually do? And
Yeah.
yeah, why is it so critical? Why is deprescribing so critical for older adults and nursing home residents?
Yeah, so when I launched the Deprescribing Clinic, I had in mind that it was going to be a lot of older adults on way too many medications and making these huge changes. And it has been some of that, but I have been surprised at the clinic. I see patients of all ages at the Deprescribing Clinic. My clinic is located inside a community pharmacy, so it's very nice that I have an office inside the community pharmacy I work at to have that continuity there. But I do see people of all ages, and I offer pharmacogenomic testing. I offer cognitive decline risk reduction, is what I call it, but basically looking at anticholinergic and medications that affect cognition. And then also I look at drug-induced nutrient depletion. So those are the big areas I focus on. I do big deprescribing services for people that are on, 30 medications, trying to get it down to something that's manageable for the patient and to decrease risk, but still appropriately treat all their comorbidities. So I will say that after launching the Deprescribing Clinic, the biggest seller, I guess you could say, or the service that people want the most is the pharmacogenomic testing, and that is people of all ages. It is kids with ADHD, young adults and adolescents with anxiety and depression, and then, of course, your older adults who are on so many different medications, and we're trying to figure out what's working, what's not, and what's probably causing too many side effects. So that is for sure the biggest service I offer, which has been a surprise to me, has been that pharmacogenomic testing.
Yeah, I'm excited to get into that. We're going to definitely. I wanted to focus on lay the groundwork here. So, from your work across 20 long-term care facilities, what are the most common medication-related problems you see? I've seen your posts on LinkedIn, and you focus a lot on anticholinergic burden. And, is so very important. And I think it's often overlooked. So what do you see most commonly that are medication related problem with anticholinergic burden, side effects, or drug induced nutrient depletion, which is huge?
Yeah. For the most common problem is definitely the prescribing cascade. So you see a patient, started a lot of times, this starts with an anticholinergic, right? So they're started on oxybutynin and pretty soon they have dry mouth. So then they're on a biotin mouth spray and they develop constipation. So they're on some Senna. And then they develop tachycardia from being on an anticholinergic. So now they're on propranolol, a beta blocker. And from being on the propranolol, they get some bronchoconstriction. So now they're on an albuterol inhaler and maybe Advair. And so you can just see how this continues, this prescribing cascade. And if you don't get to the very first medication that was prescribed, it's hard to see, the rest of the prescribing cascade occur. But I think anytime there's a new problem in a nursing home patient, let's first assume it's a side effect. Let's just first look at the meds and see, could this be a side effect instead of a new disease state or a new concern that the patient is facing? So I will say that I think the prescribing cascade is one of the biggest medication problems that I see, and it often starts with an anticholinergic. And those anticholinergic, luckily with the Beers criteria and the stop-start criteria in different organizations, really making the awareness that anticholinergics do pose a lot of risk. Now we're looking at it more, we're seeing it more, we're spotting it, and there's other alternatives for most of these medications. I look at paroxetine. I mean, it's a highly anticholinergic medication, and we have many other SSRIs that we could use as an alternative. So luckily, there's lots of alternatives we can use, and also, thankful to the American Geriatric Society and others, there's more awareness to the anticholinergic burden issue facing all of us, but especially our older adults.
Yeah. Yes. All of those things you mentioned is so very important. And another big problem in nursing homes that I've seen, and I'm sure you've seen, antibiotic use. So you are certified in antimicrobial stewardship and actively involved in this. Um, how big of an issue is antibiotic misuse in nursing homes today? And I'm just going to throw this in. I was talking with a family member yesterday who said to me, It's just antibiotics. I don't understand why the doctor doesn't just prescribe them when we ask."
Exactly.
Like that is that's huge, right? That's the issue. So, what role should pharmacists play in strengthening stewardship efforts?
Right. Antimicrobial resistance is a global public health threat. And when you look at the data, it is pretty alarming to see just how big the threat is everywhere, including the United States. So pharmacists have a huge role to play in this because we have such an involvement in both nursing homes and in the community. I will say in my nursing facilities, I take a very active role in antimicrobial stewardship, helping create policies, attending monthly antimicrobial stewardship meetings, looking at different criteria. Some of the things that we've done is we've placed a cap on the duration of antimicrobials to treat an uncomplicated UTI. We were having an issue in one of my nursing homes where UTIs were being treated for 14 days when they could probably only need to be treated for 5 to 7 days. So just looking at those kind of policies to see if we can help with resistance in our facilities. Also, why are we starting an antibiotic? Is there warrant to starting one? A different colored urine isn't a reason to start someone on antibiotics for a UTI. Your mom acting funny, we don't need to go get the UAUC right away. We could look at other things. Is she dehydrated? There's many other things to look at. So using the Loeb criteria to determine if we even need to treat a UTI is a good thing. And a lot of this boils down to education, and pharmacists can be a great resource to educating nurses and others on when it might be appropriate to look at treating and when it might be appropriate to just monitor. And so another one is even just skin. A resident takes a bath and there's redness on their skin. Well, that's not really a reason to start nystatin. Can we start with a barrier cream or an intradye sheet? Or can we monitor and start, a different intervention instead of going right to that nystatin? And so these are all ways pharmacists can be involved in antimicrobial stewardship because we do need to use these medications judiciously or we're going to have a big problem on our hands. And we already kind of do with some bacteria and some bugs like Candida auris coming and other resistant organisms.
Yeah, yeah. And I remember thinking during the pandemic, like the nursing homes, might be the place where something starts that really ruins, I don't want to say ruins, but takes down the whole world, right? Like all of
Right.
these superbugs are developing there. Like it's really a big problem. So we do need to get a handle on it. I think trying to get facilities to buy in to do deep prescribing, it's not flashy. It doesn't seem like it's going to impact the bottom line for these facilities. So people don't realize how much medication use can influence quality measures in nursing homes because it's, kind of under the surface. So, how do medication related side effects and polypharmacy quietly impact outcomes that facilities are being measured on?
Yeah, when you look at the data that nursing facilities receive and what's flagging on their CASPR report or different, measures, look at antipsychotic use, and that's a big one. So trying to get your antipsychotic use down, finding ways to manage behaviors other than going to antipsychotics. Now, sometimes you just simply can't, depending on diagnosis and other factors, but getting those rates down can help with quality measures. Preventing falls and falls with major injury. That is huge for helping out quality measures. Preventing rehospitalizations and getting your rehospitalization rates down certainly helps with quality measures. So there's a lot of areas where reducing polypharmacy and starting a deprescribing process can really help nursing homes in so many ways. But yes, improvement in quality measures. Look at even OTC medication and OTC medication use. That's something that these nursing facilities pay for. getting that down can help the bottom line. Look at the time to administer medications, safety of patients. The less medications there are to administer, the safer that those patients can be in reducing time and reducing burden. So there's many, many ways that just having patients be on appropriate medications can improve quality, can improve the bottom line, can improve nursing time, and then improve patient safety, which is the biggest goal.
Yes. And I want to kind of finish up our nursing home discussion, though I could talk for a long time because nursing homes are in my heart. But based on your experience, what is the single greatest medication related risk facing nursing home residents right now? And what does it keep you up at night, and what keeps you up at night about it?
Oh, well, lots of things keep me up at night, but the risk, of course, I think right now and kind of post pandemic is we have a shortage of people working in our nursing facilities, and that the shortage of staff leads to the decreased amount of time to do your job. And we don't want to rush through a job, but we certainly don't want to rush through dispensing medications to patients. And when you look at all the different medications patients take, giving someone the wrong medications terrifies me. I mean, I've seen it happen. I've seen someone get an Oxycontin that was never on Oxycontin and end up on a Narcan drip in the ICU. So you see these things happen and you just never want a patient to be harmed. And so my biggest fear is with shortage of people working in nursing facilities that mistakes happen, things get rushed. Do you check a blood pressure to make sure the parameters are being met to give that digitoxin or to give that beta blocker? Are you checking a person's blood sugars to ensure that you're giving them the right amount of insulin? I mean, I've seen it rushed where someone just used the blood sugars from the night before to give the insulin today. Well, that's terrifying. So the shortage and the rushed, dispensing of medications to patients and administering medications is my greatest concern as far as nursing homes and patient safety goes.
Yes, I would. Yes, agree. And I didn't see that coming as clear as the risk, that I would agree with you. So I want to get to your pharmacogenomic testing. You've incorporated this testing into your deprescribing work. How do you see pharmacogenomics changing the way we manage medications in older adults and long-term care settings as well?
Oh, I hope this begins to be used from the time, children start being prescribed medications to all the way through the entire lifespan to prevent side effects and to get the most out of medications. So, I mean, there are so many different studies, but there was one done with thousands of patients across multiple health systems where they simply did pharmacogenomic testing in one arm and normal healthcare without pharmacogenomic testing in the other arm. And just by doing the pharmacogenomic testing and using it to guide prescribing, adverse events were decreased by 30%. Well, that's a big deal because adverse events are the third leading cause of death in the United States now, if you look at that thirdcause.org. So reducing by 30% just by using the test and using it to guide prescribing habits is huge. And we know our older adults are more prone to side effects. Their kidney function is decreased, possibly liver impairment, they're more frail, more body fat, just a different body composition, less muscle mass. They're so much more prone to having side effects. So by using pharmacogenomic testing, if we can decrease that, that's huge in our older adults. And huge, honestly, in anybody who's ever going to take a medication. It's a simple cheek swab. It's covered by Medicare. Why are we not utilizing this amazing tool that we have to prevent side effects and help patients get the most out of their medications? Even looking at clopidogrel. If you have a heart attack, I mean, you certainly want to ensure you don't want to have another one. And how do you know that clopidogrel is working if you don't do a pharmacogenomics test? So I get so many people and so many providers say to me, I don't need a pharmacogenomics test because if someone's having a side effect, I'm going to switch their medications. I get that valid argument, but not for every medication. Because when you look at clopidogrel, how are you going to know it's not working until they have a repeat heart attack or some type of adverse event from that medication not working? So let's just use it. let's use that swab. Let's know if that medication is working for you or not, and let's prevent side effects.
Yeah. Very basic, straightforward, common sense.
Yes,
Yeah.
absolutely.
Yes. So looking ahead, where do you see the Deprescribing Clinic in 5 years? And maybe this is a two-part question. So where do you see the Deprescribing Clinic in 5 years? And if you were shaping healthcare policy nationwide, what role would you want pharmacists to play in caring for older adults that we're not fully utilizing today?
Yeah, great questions. When it comes to the Deprescribing Clinic, I'm so thankful that it's, been around almost 3 years now. I started, I really didn't know how it was going to go, if people were going to come. And honestly, I've never advertised. So the fact that it's still going just by word of mouth, I'm so grateful that these people trust me and come to me and want to get tested. And I love it. I absolutely love it. So I hope in 5 years, it's still going and it's reaching more people. I hope different deprescribing clinics pop up across the United States to help people. Right now I'm working on a grant, which I'm so thankful for. I'm doing a grant in collaboration with North Dakota State University. And we're doing pharmacogenomic testing in nursing home patients and tracking data as far as how many, major gene drug interactions are there, how many moderate interactions, what percentage of our nursing facility patients are a CYP2D6 intermediate metabolizer, what percentage are a poor metabolizer, number of meds before and after, pain scores, depression scores before and after. So I hope to keep doing studies like this to prove benefit of pharmacogenomic testing so that hopefully, to answer your second question, pharmacogenomic testing is more widely covered by insurance companies, because right now I can get Medicare to cover a swab under Part B with a qualifying medication and diagnosis for once in a patient's lifetime, which is amazing, but I'm having difficulty getting coverage from Medicaid and from commercial insurances and also from Medicare Advantage plans. So I would love to see more coverage for pharmacogenomic testing, because it does make such an impact and reduce side effects, reduce hospitalizations, reduce polypharmacy. So it's definitely worth the money. Studies have proven that. And also in the future, I love that pharmacists get reimbursed for dispensing prescriptions and get paid to dispense prescriptions. I think our community pharmacists have such an important role, and I love our community pharmacists. I would also like to see pharmacists get reimbursed for monetary value not tied to prescriptions. So preventing hospitalizations, preventing rehospitalizations, preventing polypharmacy, decreasing anticholinergic burden, those clinical services that we offer, I would love to see us get reimbursement for. And I know there are things like Outcomes MTM, which I do, and I'm grateful for them too, but getting paid $10 to get somebody on a statin who has diabetes is great. It doesn't do justice for what pharmacists can offer the United States when it comes to healthcare and improving healthcare. So I hope pharmacogenomics is more widely covered and pharmacists are paid for the services that they are able to offer.
I love that. That's got to be the
for the podcast.
if people want to find out more about you and your work, how can they do that?
Yeah, I'm on LinkedIn, so you can catch me there, or just the deprescribingclinic.com. You can find me there. And yes, please reach out. I love working with different people and getting kind of the word out about all pharmacists can do and the power of pharmacogenomics.
And your podcast. Let's plug your podcast.
Oh, yeah. And my podcast, the Geriatric Pharmacy, focus on the Pharmacy Podcast Network. Yes, I love podcasting.
Yes, highly recommend. Dr. Tamara Ruggles, I love this conversation. Thank you so much for joining me today.
Yes, thank you for having me.
Thank you for tuning in to Taking Healthcare by Storm, Industry Insights, with Quality Insights Medical Director Dr. Jean Storm. We hope that you enjoyed this episode. If you found value in what you heard, please consider subscribing to our podcast on your favorite platform. If you have any topics or guests you'd like to see on future episodes, you can reach out to us on our website. We would love to hear from you. So until next time, stay curious, stay compassionate, and keep taking healthcare by storm.